Our last speaker is Dr. Gina Choi, who's at UCLA, and she's a hepatologist there. And she reminded me last night at dinner that she was the one who got away because we actually tried to recruit her to USC several years ago after her fellowship at Penn. So, Gina.
Hello, good morning, ladies and gentlemen. It's a privilege to be here. So for the next 30 minutes, I'm going to give a quick update on portal hypertension from EASL and DDW. These are my disclosures, none of which will be discussed in the following presentation. So our objectives is quickly a brief portal hypertension review, and I'm going to hit upon 3 topics that I found interesting from the spring meetings. That includes management of acute variceal hemorrhage, tips in patients 70 years and older, and finally fecal transplant for refractory hepatic encephalopathy. So this slide was adapted from the maven of portal hypertension, Dr. Garcia Sao, where we talk about cirrhosis, and the end stage of chronic liver disease has 2 main prognostic stages. So you have chronic liver disease that could be from any variety of reasons: alcohol, cholestatic autoimmune liver disease, viral hepatitis, NASH. And this can and may lead to compensated cirrhosis, which is asymptomatic and often difficult to diagnose. We have non-invasive things like FibroScan, MR elastography, platelets. Ultimately, this can lead to decompensated cirrhosis, and at that time, your median survival is about 2 years, and that's when you have symptoms of cirrhosis, which include ascites, variceal hemorrhage, hepatic encephalopathy, and jaundice. And of course, this can lead to death. So the degree of portal hypertension is the main driver of decompensation. So when you get clinically significant portal hypertension, that's when you start getting into trouble with decompensation and death. So I kind of put this up as a quick kind of review of the pathophysiology of cirrhosis and portal hypertension. So we know that in portal hypertension, basically it's the result of increased hepatic resistance, and this leads to a cascade of trouble, which includes splanchnic vasodilation, hypotension, effective hypovolemia, activation of vasoactive systems, sodium and water retention, hypervolemia, increase in cardiac output, increased portal venous flow, and finally portal hypertension. And the red words here kind of tell you how we address each of these different stages, hoping that we can slow the progression of this process. So now let's get to that's what we know about portal hypertension. Let's get to now what was new about portal hypertension, both at EASL and at DDW. So let's start with management of acute variceal hemorrhage. So as gastroenterologists, we know how scary acute esophageal variceal hemorrhage is. And I think it's very important to remember how high the mortality is in acute variceal hemorrhage. It's a very, very poor prognosis. It's often related to the severity of the underlying liver disease. And standard therapy, which includes endoscopic treatment, usually fails within 5 days in a quarter of patients. And this results in a 6-week mortality of about 30%, particularly in patients with child C cirrhosis. So for the management of acute variceal bleeding, we know you want to transfuse starting at a hemoglobin of 7 to maintain between 7 to 9, to start antibiotics and vasoactive medications, which in the United States includes octreotide, EGD within 12 hours of admission. And if you look at the treatment guidelines, they say tips in patients with high risk of bleeding, and high risk was categorized as Child's Pugh C cirrhosis, or B 10 through 12, with active bleeding on EGD, with of course no contraindications to TIPS. So where did this TIPS suggestion come from? So let's go back to 2010 to this New England Journal of Medicine paper from Spain, where they said early use of TIPS in patients with cirrhosis and variceal bleeding. So basically, the take-home point from this landmark study was that survival at 6 weeks in the early TIPS group was 97%, and 67% in the group that received esophageal band ligation. Survival at 1 year was 86% in the early TIPS group and 61% in the medical EBL treatment group, with a p-value of 0.001. They screened about 350 patients for this trial and enrolled about 30 patients per group. However, this paper wasn't perfect. I think some of the pros that were associated with this was that they used clinical data, not HVPG, to identify patients for the study. It was randomized, it was controlled with intention to treat analysis, and they used covered stents. So prior to 2004, our interventional radiologists were using bare metal stents, but now they're using covered stents, which is actually better in terms of efficacy. And they also mentioned hepatic encephalopathy in this study, and they interestingly said that there was no increase increase risk of hepatic encephalopathy among the patients who receive TIPS. However, there are a lot of naysayers to this study as well. They always say there was a small subset of patients recruited, only 18% that were screened were actually put into the study. It took them over 34 months to recruit the 63 patients, so you ask yourself, is this really representative of the patients you see coming through your emergency room? Most of the patients, 20 out of the 30 in each group, had alcohol as the etiology of liver disease. So maybe they all got better in terms of survival at 1 year because they stopped drinking. And finally, subsequent observational studies did not confirm the effect of early TIPS on survival. So with that background, I'm going to take you to the very first abstract I'm going to present. It's from EASL PS024, early TIPS with covered stent versus standard treatment for acute variceal bleeding in patients with advanced cirrhosis, a randomized control trial. And this study actually came from China, so this is China's response to Spain's 2010 study. So background and aims, again, early TIPS improve survival in Child-Pugh B and C, 10 through 13 cirrhosis with active bleeding and endoscopy. And the question is, can this be validated and achieved in a broader population compared to what they did in Spain? So in terms of methods, they did consecutive patients with Child B or C cirrhosis, acute variceal bleeding. They were either given to vasoactive drugs and endoscopic therapy, which in China includes terlipressin, which we do not have in the United States, 2-to-1 to early TIPS, and early was defined as within 72 hours after initial endoscopy, so everyone got endoscopy, or continuation of vasoactive drugs to day 5, followed by beta blockers, and of course, repeated banding until obliteration. And the primary endpoint was transplant-free survival. So in terms of the results, they were able to enroll 129 patients between June 2011 to September of 2017. So again, after 2004, 84 went to early TIPS, 45 went to medical therapy and banding. And they saw that the transplant-free survival was higher with the early TIPS group versus the one who got endoscopic therapy and medication. And they went so far as to say 6 weeks, 99% versus 84%, 1 year, 86% versus 73%, 2 years, 79% versus 64%, red being the early TIPS group, the blue being the endoscopic therapy and medication group. So in addition, they found that early TIPS in this Cox regression analysis, that early TIPS was associated with a 56% relative risk reduction in mortality or transplantation at 2 years, and it was beneficial in most subgroups. They try to diversify the the degree of liver disease that these patients had. Early TIPS was also associated with a decreased risk of failure to control bleeding and rebleeding. But they interestingly had new and worsening ascites, which you would not expect in the TIPS group. And they also reported, just like they did in Spain, that there was no increase in frequency or severity of overt hepatic encephalopathy and other adverse outcomes. So they concluded that early TIPS is superior to endoscopic therapy and medication in improving transplant-free survival and reducing failure to control bleeding. Early TIPS is associated with new worsening ascites without increasing the risk of overt HE, and their results favor the early use of TIPS in patients with advanced cirrhosis and acute variceal bleeding. So what do we think about this? So it's good in that it confirmed the effect of early TIPS on survival in a different cohort than the one we saw prior, so Spain versus China. And it's kind of interesting that both studies did not see an increased risk in overt hepatic encephalopathy. Both studies also had new and worsening ascites. But I think the key here is that patient selection remains key and requires further delineation. So I kind of want to see their table 1. What was the etiology of liver disease, et cetera? And as Dr. Toro said earlier, the devil's really in the details. So when you think about this procedure, it's just like when you think about steroids for acute alcoholic hepatitis. Not everybody with acute alc-hep should get prednisone, but really is that who is that sweet spot, that magic group of cohort of patients who will actually benefit from this therapy. So my opinion is that TIPS remain salvage and should not be prophylactic at this time. So going to our second topic, I'm going to talk about TIPS in patients 70 years or older. So I actually saw this patient in clinic 2 weeks ago. So 73-year-old man, alcohol, mild sodium 9, Child-Pugh B, refractory ascites, adherent to 2 grams a day, gets a para every 2 weeks, no HE, but definitely sarcopenic. And his sodium is 130, the bili is 0.9, INR is 1.1, creatinine is 1.16, and said to me, I'm not interested in a liver transplant. So when we think about refractory ascites treatment, we have large volume paracentesis, which is great symptomatically, but the fluid comes back in a snap. It does not correct the mechanism of fluid formation, if you could think back to that pathophys slide I started with, and it does not impact survival. So then we do have TIPS for this, and TIPS relieves portal hypertension. It does reduce the occurrence of ascites, and studies have shown that it improves survival. So what is that study? So this was a meta-analysis that's often quoted in the literature from 2007 from Gastro. And basically they say that TIPS for severe ascites improves transplant-free survival. So they compare TIPS versus paracentesis. And you see here that at 6 months, 12 months, 24, and 36 months, TIPS is better than repeated paracentesis for transplant-free survival. However, if you keep reading the paper, they say that the estimated probability of death after TIPS for ascites is contingent upon certain factors. And the factors they always talk about are age, and here they did from 50, 55, and 60, poor liver function as evidenced by your bilirubin, and hemodynamic dysfunction as evidenced by your sodium. So if you look at a patient, right, their mortality at 18 months, if they're 50, with the bili of 1 and sodium 140 is 15%. When you're 60 with the bili of 3 and a sodium 130, your mortality is 80%. So I think when people see this data, they say, whoa, 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 maybe I really shouldn't be thinking about TIPS in the elderly. And then there's also, in addition to mortality, you also need to think about hepatic encephalopathy after TIPS. So it's a known complication of TIPS, but if you look back to all these studies ranging from 1990 to 1997, that's me actually reading these papers, they're all very small. The types of stents used was, again, the bare metal, not the covered stent. And it's really difficult to define this endpoint in studies because often it's very subjective, and many factors can precipitate HE. How do you know they didn't have an infection? How do you know they didn't just bleed, et cetera? But I think the general words of wise is use with caution if you're 55 to 65 years of age, if you're a man, and if you have a high MELD, which is anywhere from 18 to 20. So this leads us to our next abstract after that background, abstract number 1057, Outcomes After TIPS in Cirrhotic Patients 70 Years and Older. And this actually really appealed to me based on that patient that I saw. And so we know that as the population ages, an increased number of older patients with cirrhosis are presenting for complications from portal hypertension and cirrhosis that may benefit from TIPS. And prior studies evaluate TIPS in patients 60 and older, 55 and older, but data specific to 70 years and older are limited. So they wanted to see how patients did in TIPS when they're 70 or older. So it was retrospective, and it was again between 2008 and 2018, all decompensated cirrhotic patients. It was a single center, and they basically matched 70-year-olds with 60 or less years of age, also based on their MELD score, and they collected a bunch of information, demographics, etiology of liver disease, 30-day mortality, and readmissions. They defined HE as West Haven classification, and actually the dose of lactulose or rifaximin administration, and finally the length of hospital stay. And they used Fisher's exact test to compare proportions. So they were able to review 452 patients received TIPS at their center between this time frame. They actually included 100 patients in the study. 50 patients were greater than or equal to 70 years, 50 less than or equal to 60. And the median age in the elderly was 73, from 70 to 84, and the median age in the non-elderly was 55, with a range of 50 to 59. So a little bit more in terms of the demographics. So their average MELD sodium in the older group was 11.5, and the younger group was 11. The cirrhotic etiology for the older group was non-alcoholic fatty liver disease, predominantly in Hep C in the younger group. And the most common indication for TIPS in the older group was ascites, and the most common indication for TIPS in the younger group was variceal hemorrhage. So in terms of outcomes, so here we see pre-TIPS, the younger people had more encephalopathy than the older group. Post-TIPS, it was about the same in terms of hepatic encephalopathy. The median post-TIPS length of stay was longer in the older group. The 30-day readmission was higher in the older group, and the 30-day mortality was also higher in the older group. So their conclusions are that they had a large number of patients over the age of 70. In carefully selected elderly patients, post-TIPS HE is not increased in the short term. However, they had poor survival, which is bad, and higher readmission rates were also observed. So our conclusion, I think the pros of this study is retrospective, but they did have a large number of elderly patients. The definition of elderly patients was, I think, appropriate because prior studies used 55 to 60. They defined HE clearly, and it was a pretty recent cohort from 08 and 2018 when our radiologists are a little bit better at TIPS. However, their cons is that in contrast to the review that I had mentioned earlier, the meta-analysis, they had poorer survival, and again, it was retrospective. So tips in the elderly, the takeaway home points are that prior, when we thought about tips in this cohort, it was always thought of as a bridge to transplant. But I think nowadays, given the elderly population, we're thinking of it more as definitive treatment. Age should be considered, but it should not be a hard stop. You should balance that with other prognostic factors: bilirubin, sodium, creatinine, sarcopenia, and hepatic encephalopathy. And you also need to think that our radiologists are really good now, so you need to communicate with them. Can you make this the narrowest tips possible? Or if you went too big, can you actually revise the tips to make it smaller? And I think for future studies, it's really important that we very carefully delineate how we define hepatic encephalopathy. So finally, I'm going to talk about fecal microbiota transplant for refractory hepatic encephalopathy. So, when we think about hepatic encephalopathy and the microbiome, it's so hot right now. And I think that the liver folks have actually been in tune with this for quite some time. And this is just a schematic of the gut-liver axis. And basically, we know that patients with cirrhosis have a severe dysbiosis in their gut microbiome. So they have bacterial overgrowth, they have epithelial barrier disruption, they have alterations in bile acid production, and ultimately immune dysfunction, which leads them to have a sequela of an altered microbiome and all the repercussions therewith. So in 2017, this paper appeared from Bajaj in Virginia, where he talked about, well, everyone's talking about the microbiome. What if we were to apply that to patients with cirrhosis and refractory hepatic encephalopathy? So here we have a paper, Fecal Microbiota Transplant from Irrational Stool Donor Improves HE. So basically, it was like a trial. They took 10 patients, they followed them for 5 months, and they noted reduced hospitalizations, improved cognition, and improved dysbiosis. And they actually measured cognition using the Stroop test, which is an app you can get on your iPhone. So but then the big criticism of that study was, well, you only follow these people for 5 months. So, can we have some long-term data? So in Gastro 2019, they actually did long-term outcomes of fecal microbiota transplantation in patients with cirrhosis. More than 12 months of follow-up, and they found that standard therapy, people got lactulose or rifaximin, fecal transplant, and they found that they actually had less hospitalizations and less episodes of hepatic encephalopathy, 10-1 versus 8-0, with significant p-values. So then they thought about this and they said, well, the prior studies weren't that good because they lacked a placebo control. The fecal microbiota transplant was via an enema, and so patients really didn't like that. So they said maybe we could do something more oral, like a capsule. And also the really tricky part was that in these people who got the enema, they also got days and days of pre-intervention antibiotic therapy. So the data suggests that antibiotics promote FMT engraftment. However, the naysayers say, well, how do you know what was the cause of the improvement? Was it the pre-antibiotics or was it actually the enema transplant? So this is what led to DDW abstract number 245, where they talk about fecal microbiota capsules are safe and effective in patients with recurrent HE, a randomized blinded placebo-controlled trial. And again, it's from the same group of people that did the 2 prior studies mentioned. So their aim was to determine the safety, tolerability, and impact on brain function and the consistency of the microbiota using capsular FMT versus placebo in recurrent HE. And so they basically took cirrhotic outpatients with recurrent HC, randomized 1-to-1. They got 15 capsules or placebo. They did endoscopies with duodenal and sigmoid biopsy, stool analysis, cognitive function, the duodenal antimicrobial peptide analysis to kind of see what bugs are present. MRAs were assessed 2 and 4 weeks post-treatment with 5-month follow-up. Everyone got lactulose and rifaximin throughout, and patients who underwent the FMT got repeat endoscopies 4 weeks post. So they got 20 subjects who were randomized. They did Table 1, microbiota diversity, inflammation, AMP expression, and brain function were all similar at baseline, and the MELD was also similar with FMT versus placebo, with baseline being 9 versus 10, and study end 10 versus 10. So this is the table. So we again see that hospitalization rate was significantly lower versus placebo, FMT versus placebo 1 versus 6 with a significant p-value, and improved cognitive function through that encephalop that we discussed earlier was improved with FMT with the p-value of 0.02. This is the 4 weeks post-treatment. They talk about the duodenal mucosal diversity increased, and they kind of say the relative of abundance of certain microbes that are considered more beneficial and decrease in the ones that are considered not so good, and improved barrier function as reflected by E-cadherin, IL-6, and defensin A5. So the author's conclusions is that oral FMT was safely tolerated, that oral FMT led to enhanced encephalop performance in cirrhosis in recurrent HE versus placebo, and that it was associated with lower hospitalizations, improved duodenal mucosal diversity, dysbiosis, and barrier function. However, in terms of what we think about FMT and hepatic encephalopathy, I think that our takeaway points are that microbiome therapeutics are very tricky. Did FMT produce these outcomes? I think that there's it's almost like a needle in a haystack type scenario where was it actually the microbiome? Was it the host interaction with the microbiome? Was it the host? I think all these things are still yet to be extrapolated. And of course, are these results reproducible at other sites? So all this study has all come from the same set of authors in the same institution, and no one else has tried to replicate these things. Kind of the same thing that Barcelona had in terms of tips in acute variceal bleeding. Of course, stool content and screening. So what is in the stool? How do we choose what goes in the stool? Where does the stool come from, et cetera? And finally, is it safe? Which the authors actually said it was safe. However, someone alerted me recently that fecal transplant is linked to a patient's death. The FDA warns. This came out in the New York Times on June 13th, 2019, where they said that 2 patients received donated stool that had not been screened for drug-resistant germs. So it led to a halt in clinical trials until researchers provide proper testing procedures. And what happened was that these 2 patients contracted severe infections, and one of them died from fecal transplant that contained MDR E. coli. So in summary, we know that portal hypertension is the main driver of decompensation. TIPS in acute variceal hemorrhage remain salvage, not prophylactic therapy. TIPS in patients greater than 7 years of age consider all factors, not just age. And fecal transplant for refractory HE is not yet ready for prime time. Thank you.